Do you think you've mastered emergency medicine? Let's put your knowledge to the test. This trivia challenge will cover 4 crucial topics: advanced cardiovascular life support, critical illness syndromes, organ system emergencies, and trauma. Each topic includes 3 questions, 1 easy, 1 medium, and 1 hard, worth 1, 2, or 3 stars. You'll have a moment to think, and then we'll reveal the answer along with a quick explanation from Lecturio's expert content. Keep score as you go and see how strong your emergency medicine knowledge really is. Let's get started. Advanced cardiovascular life support. Let's start with an easy one. In the context of high-quality cardiopulmonary resuscitation, what is the recommended rate of chest compressions for adult patients?
So let's start with compression rate. There have been a number of studies looking at rate, and this is one example. In this study, they looked at the mean rate of chest compressions among a large sample of cardiac arrest patients, and they found that the patients who had compressions at a rate of roughly 100 to 120 had the highest probability of ROSCE, which stands for return of spontaneous circulation, and they also had the highest probability of survival to hospital discharge, or having a longer-term positive outcome. So 100 to 120 is the rate you want to go for, and there's actual science showing us that patients are more likely to survive when we use that rate.
Now, let's move to something a bit more challenging. Based on the ECG provided, which of the following is the most likely diagnosis?
Here's one of our shockable rhythms. This is ventricular fibrillation. It's very easy to identify. It's randomly fluctuating. It goes up and down. There's no pattern. There's no rhyme and reason. There's no QRS complexes. It's just a disorganized squiggle. The second one is ventricular tachycardia. Now, in VTach, there actually is organization to the QRS complexes, but they're wide and bizarre looking. So anytime you have a fast rhythm with wide QRS complexes, you should suspect that to be ventricular tachycardia.
Let's dive into a tough one. Which of the following statements regarding cardiac arrest and CPR is correct?
When you look at the cardiac rhythm in patients with cardiac arrest, about a quarter have either ventricular fibrillation or ventricular tachycardia, which are known as the shockable rhythms. Among those patients, you have about a 30% survival rate. The remaining rhythms, which are pulseless electrical activity and asystole, only produce about a 10% survival rate. So there's a big difference in how likely you are to survive based on what type of rhythm your heart goes into at the time of arrest.
Critical illness syndromes. Let's kick things off with a simple one. Which of the following statements correctly reflects the appropriate initial management of anaphylaxis?
As far as your medical management goes, epinephrine is absolutely the correct answer. It is the mainstay of management, and if there's only one drug that you're going to give to a patient with anaphylaxis, it should be epi. Epi is given intramuscularly at a 1 to 1,000 concentration, okay? Again, you don't have to memorize a whole heck of a lot of drug doses cold, but this is one that you really need to know. You don't want to be fishing around in your phone or looking at a book when a patient is anaphylaxing. You want to know the correct dose and concentration of epi. So we give it through the intramuscular route at the 1 to 1,000 concentration, and the adult dose is 0.3 to 0.5 milligrams. The pediatric dose is 0.01 mg per kg, so you can calculate that based on the child's actual or estimated body weight. But for an adult, very straightforward, 0.3 to 0.5. This can be repeated every 5 to 10 minutes as needed, But if you're having to give multiple repeat doses of epinephrine, you probably want to think about starting an IV epinephrine infusion so that you can more satisfactorily manage your patient over a longer period of time.
Here comes another intermediate level question. Which of the following correctly lists the components of the qSOFA score and their respective cutoff values for identifying patients at risk of poor outcomes from sepsis?
So in the ED, we use the qSOFA, where the Q stands for quick. The qSOFA is very easy to remember. It's only got 3 parameters. Altered mental status, which is defined as a GCS of anything less than 15. Tachypnea, which is defined as a respiratory rate greater than 22. And hypotension, which is defined as a systolic blood pressure of less than 100. If you have any 2 of these 3 criteria in the setting of an infection, you have an increased risk of death or prolonged hospitalization. This is a clinically validated tool that reliably predicts who's going to do well and who's not going to do as well in the setting of infection. So it's very useful for us for prognosticating in the emergency department setting.
Time for a hard one. A 22-year-old male is found agitated, diaphoretic, and hyperthermic with dilated pupils. His heart rate is 130 beat per minute, respiratory rate is elevated, and his blood pressure is 160 over 90 millimeters of mercury. Which toxidrome most accurately matches this clinical presentation?
All right, so here's a review of the toxidromes, and I'm going to highlight some of the things that differentiate them so you can remember. Sympathomimetics, these patients will present hypertensive and tachycardic, and typically their mental status will be agitated. Anticholinergic patients will look a lot like sympathomimetic patients, except they will have very dry skin, very dry secretions. By contrast, our cholinergic patients will be copiously wet. They'll have diaphoretic skin, they'll have increased secretions, and they typically will be somnolent rather than agitated. Our sedative hypnotic patients will, of course, be sedated, and our opioid patients will also be sedated. However, they'll present with meiosis and respiratory depression.
Organ system emergencies. Here's an easy one to warm up your brain. Which of the following is the most common cause of acute pancreatitis in adults?
So a number of things can lead to this. So biliary tract disease is probably the most common cause, about 40% of cases, due to stone impacting in the common bile duct, or at the point where, say, the duct of Wirsung dumps into the ampulla of Vater in the duodenum. Alcohol is going to be about 30% of cases. It's idiopathic. In another 20% of cases, this may actually be due to microlithiasis, so sludging within the drainage of the pancreas.
You're doing great! Let's step it up with an intermediate question. A 67-year-old man with diabetes and a history of elevated blood cholesterol and hypertension comes to the hospital complaining of feelings of indigestion in his upper abdomen and lower chest. He is sweating and has low blood pressure. His heart rate is 52 beats per minute. What is the most likely diagnosis?
This is an acute inferior wall myocardial infarction. Notice, let's look at leads 2, 3, and AVF. Remember, those are the inferior leads. 2, 3, and AVF, look at the ST elevation that you see here. That ST elevation, now marked in the green boxes, is quite impressive. It's probably about 3 or 3.5 millimeters, and it suggests, oh, this is an inferior MI. Right coronary is probably involved, or at least in the vast majority of cases. Notice, how do we know that this ST elevation is real? We know it because leads 1 and AVL that are looking from a different direction actually have the opposite. They have ST segment depression. This is a mirror image of the ST elevation in leads 2, 3, and AVF, and it tells you this is the real thing.
Ready for a challenge? Here's a tough one coming your way. A 45-year-old man with a history of hypertension, hyperlipidemia, and diabetes mellitus, not on antiplatelet treatment, presents for right-sided weakness and speech dysfunction. The patient went to bed last night in normal health. Per his wife, the patient did not have symptoms and was able to speak normally when he awoke this morning. Around 10:30 a.m., he went to his shed to work in his shop. At around 11:30 a.m., his wife found him on the floor of his shed. He was mumbling and couldn't move his right side. Examination shows left MCA syndrome with right hemiplegia and expressive overreceptive aphasia. A CT scan of the head is performed. CTA shows left MCA occlusion. The patient receives IV TPA followed by thrombectomy for clot removal and is monitored in the ICU for 24 hours. He is transferred to the floor for further workup. What is the best next step in the workup of this patient?
Well, we don't need to repeat the CTA, we just saw that. And there's an acute obstruction of the left MCA branch. There's been no change in the patient's clinical status and no reason to repeat this imaging study. We don't need to start clopidogrel. Clopidogrel is used for secondary stroke prevention, but we often begin with aspirin. And at this point, we need to understand the cause of this patient's stroke before initiating secondary stroke prevention. We don't need to first evaluate for obstructive sleep apnea. Obstructive sleep apnea is associated with stroke. Evaluating obstructive sleep apnea is a part of our stroke workup, but that's not the best next step. For this patient, we would proceed with an MRI of the brain. This will help us to evaluate the extent and distribution of the stroke, and understanding the distribution will help us to figure out what the cause is.
Trauma. Starting off light with an easy question. A 29-year-old male presents after a stab wound to the chest. He is hypotensive, tachycardic, and in respiratory distress with absent breath sounds on the left and tracheal deviation to the right. What is the most appropriate initial management step?
So what are we going to do to treat a tension pneumothorax? Very simply, the first line treatment is needle decompression. And what we're doing when we decompress the lung is allowing air to get out of the pleural space. So if I've got a big high pressure air collection here in my chest, the goal of decompressing is to make a conduit between the inside of my chest and the outside world that'll let that air escape. And what's going to happen is that's going to equilibrate the pressure inside of my pleural space with the atmospheric pressure. However, it's not going to make my pneumothorax go away. It's not going to actually restore negative pleural pressure. I'm still going to need a chest tube, but it's going to decompress the large air collection that is mechanically interfering with my cardiac function and my pulmonary function, and it's going to improve the clinical status of the patient very rapidly. So I do want to emphasize, it's a temporizing measure. It's not definitive treatment. What you're really doing when you decompress is you're taking a tension pneumothorax and you're converting it into a simple pneumothorax. Needle decompression is also not indicated for simple pneumothoraces because it doesn't do anything for those patients. We only use it for unstable patients with tension pneumothorax, and the goal is to restore their normal perfusion and normal oxygenation while we go about providing them with definitive treatment.
Here's an intermediate level question for you. A 34-year-old male presents to the ED after falling off his bicycle and landing directly on his outstretched arm. On exam, he is unable to extend his wrist and has weakness with thumb abduction. Sensation is decreased over the dorsum of the hand. Which of the following nerves is most likely injured?
I just wanted to take a minute to demonstrate the motor assessment of the hand. So the radial nerve provides wrist extension, meaning the ability to pull the wrist up, and thumb abduction, the ability to give a thumbs up sign and keep the thumb up away from the rest of the hand. Those are radial nerve functions. The median nerve provides flexion of the first through third digits, so the ability to bring the fingers down against resistance. Also thumb opposition, so the ability to bring the thumb in against the fingers, and you can assess that by giving the OK sign and seeing whether or not the patient can prevent you from pulling through. Lastly, the ulnar nerve handles finger abduction and adduction, so the ability to pull the fingers apart against resistance and the ability to pull the fingers together against resistance. These are simple exam maneuvers that you can do to assess the integrity of each of the three nerves that innervate the hand.
Let's end strong with a tough one. A 45-year-old man presents to the emergency department after falling from a ladder approximately 4 feet. He briefly lost consciousness and now reports retrograde amnesia lasting about 40 minutes. His GCS is 15 1 hour after the injury. He has vomited once but denies headache or seizure. He is not on anticoagulants and has no history of seizure disorder. Neurologic examination is normal. According to the Canadian CT head rule, what is the most appropriate next step in management?
And the set of rules that we use for adults are the Canadian head CT rules. These apply to any patient who has a head injury with either loss of consciousness, amnesia, or confusion afterwards. So we wouldn't even be applying the Canadian rules to patients who are completely alert, appropriate, didn't lose consciousness, remember everything. We wouldn't even be talking about those patients. Those patients would not be CT'd. But if they have a head injury and they have some subtle complicating factors such as losing consciousness or being confused afterwards, we can apply these rules to them. They have to be in the age range from 16 to 65, so these rules do not apply to children and they do not apply to older adults. That's very important because, again, older adults have much higher risk of bad outcomes with minor head injury, and we want to be more aggressive about imaging those patients. They also do not apply to any patients who are on anticoagulation or have any evidence of post-traumatic seizure activity. So if your patient fits into one of these categories, you would not want to use these rules. You would want to go ahead and obtain imaging. But assuming they're healthy, they have no seizure, they're in the appropriate age range, and they just maybe have a little subtle confusion or amnesia after the event, the Canadian head CT rules are for them. So the criteria that should prompt you to get a head CT include any abnormal GCS more than 2 hours after the injury. So maybe the patient comes in immediately after the injury and they're a little bit off, they're a little bit confused, their GCS is 14. We would expect their sensorium to clear and we would expect them to have a normal GCS by 2 hours. If they don't, we want to go ahead and image those patients. If they have any evidence of open or depressed skull fracture, and we'll talk about what clinical signs we'd be looking for in just a moment, we want to go ahead and CT. So we want to really get a good look at these patients' heads. We want to palpate all over the skull and make sure that we're satisfied that there's no evidence of fracture. If they have any signs of basilar skull fracture, which are listed right here, there's a whole laundry list of them, but basically any bleeding in the ears, any drainage of CSF from the nose or the ears, bruising under the eyes, any kind of neurologic deficit, vertigo, tinnitus, nystagmus. These are all things that should make us concerned about skull base injury, and we would always want to image those patients. Patients who have multiple episodes of vomiting, we want to image. It's not uncommon to vomit once after a head trauma, but you shouldn't have persistent vomiting. So if you vomit more than once, you probably deserve a head CT. Retrograde amnesia greater than 30 minutes prior to the event should also prompt a head CT. And dangerous mechanisms, which include pedestrian-struck by motor vehicles, falls greater than 3 feet, and motor vehicle collisions where the occupant is ejected out of the car.
And that's a wrap. How many stars did you earn? If you scored 3 to 12 stars, you're an emergency medicine rookie on your way to mastering the field. 13 to 25 stars? It makes you an emergency medicine pro. You've got strong fundamentals. And if you earn 26 to 36 stars, congrats. You're an emergency medicine master. No matter your level, keep sharpening your skills with Lecturio, your all-in-one study companion for success in emergency medicine. Drop your score in the comments and let us know which topic you want next.